I am Lindsay Couch, and this is my CDS 898 case presentation. Demographic information. My patient is an adult male. He is less than 30 years old. He is unemployed. He lives at home with his mother, and he was previously an IV drug user, but he is in remission. And I'm not going to list the facility on this presentation because it's a small town and I'm afraid that it will give away his identity. Presenting problem. My patient was admitted to UK hospital following an intracranial hemorrhage secondary to a ruptured mycotic pseudoaneurysm. He was discharged from UK hospital and sent home, but shortly after he was sent home, he developed seizure activity and was readmitted to the hospital. Following the seizure activity, he was discharged from UK, but admitted to our swing bed program at the hospital just for rehabilitation. His chief complaints include difficulty making wants and needs known, and then difficulty with word finding. Clinical evaluation and medical history. My patient's clinical evaluation and medical history revealed that he is 5'6" and 140 pounds. He was diagnosed with endocarditis at UK hospital. As previously stated, he presented with an intracranial hemorrhage secondary to a ruptured mycotic pseudoaneurysm, and then he did develop seizure activity as a late effect of a CVA. And he currently has hemiparesis affecting his right side, and then also while at UK, he underwent a craniotomy. He is on a list of current medications. He takes Simitril, which is an antiviral, Dulcolax, which is used to treat constipation, Dantrium, which is a muscle relaxant, Famotidine, which is an antacid, Vistaril, which is used to treat anxiety, Lactobacillus acidophilus, which is a probiotic, Keppra, which is used to treat seizures, melatonin, which is a sleep aid, Zofran, which prevents nausea and vomiting, polyethylene glycol, which is also a laxative, and then Zoloft, which is used to treat depression. Social support. My patient is single and he has no children, but he has very strong support from his mother. Besides his mother, he doesn't get any visitors that I've seen. I haven't seen any friends that have come and visit him, but his mom is there every day, every evening when we take him back from therapy. Focal problem. My patient's swallowing was deemed within normal limits at UK hospital before being discharged to the swing bed program. He is on a regular diet besides his meats, and his mother stated that she chops his meats just because he tends to eat fast. We did conduct informal assessments to gather information on his language and speech skills. So for his auditory comprehension, his picture identification was unimpaired, and with this we named a picture and then he pointed to the correct one out of a field of 3. For yes-no questions, cues were required, and then to follow commands, cues were required for greater than 2 steps. For verbal expression, he has repetition, automatic speech, picture naming, sentence completion, response length, and intelligibility were all impaired. For social interaction, his eye contact was unimpaired, but his conversation initiation and his topic maintenance were both impaired. And then he was impaired with his orientation to person, place, and time. So his problems noted were auditory comprehension, verbal expression, and intelligibility of speech, and he was diagnosed with expressive or Broca's aphasia and verbal apraxia. Treatment plan. My patient receives therapy 4 times a week for 30 minutes a day, which is required for the swing bed program. He has 2 long-term goals. The first one is that the patient will comprehend basic conversational exchange with no difficulty, and the short-term goal that goes with that is that the patient will follow basic directions from a text. The second long-term goal is that the patient will gain the ability to use words to communicate, and the 2 short-term goals are that the patient will imitate a song with appropriate prosody and that the patient will imitate CV and VC word combinations. So for his first short-term goal, the clinician writes a one-step direction on a marker board. So for example, point to your head, and the patient is instructed to perform that activity. For the second short-term goal, the clinician and patient sings a familiar song such as Happy Birthday or Row, Row, Row Your Boat. And for the third short-term goal, the clinician presents various apraxia cards to the patient, and the words are those such as mo, ba, and pa, and instructs the patient to produce that word. If he produces the word incorrectly, visual cues are provided, and he responds very well to the visual cues. My patient is very compliant and he works really hard. He'll do anything that I ask him to, but he is very self-conscious of his errors. He acts more self-conscious around me rather than my supervisor because my supervisor is a male. So I think that he is a little bit more self-conscious around females, but I think he's getting better as we begin to see him more and he's getting more used to working with me. But he knows when he produces a word incorrectly and he's very self-conscious about it. But no changes or adjustments have been made with this patient because we have only been seeing him 1 week. We could probably change or adjust our treatment depending on how he does as we see him for a longer period of time. Outcomes. The patient's current level of functioning isn't too varied from baseline since we have only been working with him for about a week. However, he is making great progress, especially in following written directions. But he does still struggle with producing VC and VC words, but that is expected with apraxia. He's still highly unintelligible right now, and he still does require a communication board to communicate. But he does use this board and he uses it consistently. So I believe that they worked with him at UK to use this board because he did come. He did come to the swing bed program with the board that he's using. And it still hasn't been decided when he will be discharged since he is admitted to the swing bed program. These patients can stay longer than a regular hospital, and it's mostly used for rehab. However, his mother stated that she was going to continue to bring him to the hospital for outpatient speech therapy. I think that he will get occupational therapy and physical therapy through home health, but currently in our town there's not a speech therapist that does home health visits. Summary. I have learned so much so far with this patient. I'm so glad that I had the opportunity to work with him because I'd never worked with an adult patient with apraxia before. So it's interesting to see how it presents and how it's treated. But if I could change one thing about the intervention process since he's still in therapy, it would definitely be to include his friends and family. His mother is there every day, but she generally doesn't come until we take him back to his room after therapy, and I haven't noticed that he's had any visitors other than his mom. So I feel that including some of his friends in his therapy and then him seeing how supportive they are will lessen his anxiety because he's very anxious about how he sounds and he doesn't realize that he will get better over time, and he's really, really self-conscious. But in the future, to treat similar cases, I definitely need to learn more about evaluating and treating adults with apraxia since this is my first patient. And I also need to learn more techniques on building patient self-esteem because I've learned that it definitely has a negative impact on therapy. When his self-esteem is low, you can tell that he does not perform as well in therapy and he just gets very aggravated and just really gives up when he doesn't respond how he expects.